Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center in Miami with our weekly Monday afternoon chat. Today's topic is how do I get pregnant if I tied my tubes? A lot of women undergo tubal ligation and men vasectomies to prevent future fertility when they think they're finished having a family. And statistically, although when you're doing this, when you have a tubal ligation, most women are advised that this is a permanent situation and they feel pretty comfortable that they're not going to have additional children. Well, statistically, about 5% of patients who have tubal sterilizations or tubal ligations end up wanting additional children, and life situations change over time. And certainly that presents a dilemma because, as we've spoken before, in order to get pregnant, we need a uterus, ovary, sperm, and a way for the egg and sperm to get together. So normally, fertilization occurs in the tube. After ovulation takes place, the tube picks up the egg and transports that egg towards the uterus. The sperm, which get up into the vagina, find their way up into the cervical mucus, swim up into the uterus and into the tube, and actually fertilize the egg in the tube itself. And then you're reliant on the tube and the internal architecture of the tube to then transport this embryo back to the uterus. So a sperm has its own propulsion device, but once it fertilizes an egg, the egg has no way to move unless something moves it. So there are these inner cells on the inside of the tube called the ciliated cells that gently transport this embryo back to the uterus where it implants and then pregnancy develops. So obviously tubal ligation, so as tubal sterilization, interferes with that and works as a great means of sterilization. It's 99% effective in preventing pregnancy. There's multiple ways the tubes can be blocked. Historically, you can cut out a section of the tube. Some people burn and cut at the tube. Some people burn it in multiple places. Some people remove the whole tube. Some people loop the tube and cut a little piece out. Newer methods were using what's called an E-Shore device, which was available for a bunch of years, where you can put this device up through the uterus into the beginning of the tube, and it would block the tube at the first portion of the tube. So most commonly tubal ligations were performed either after childbirth a few days later, or what's called interval tubal ligation, which is done not immediately following pregnancy. The result's the same. You have a blockage in the tube. So how do you get pregnant if there's a blockage in the fallopian tube? There are two basic options. One is one can consider repairing the tube, and the other is to bypass the tube. So the first option, which is not usually my best recommendation, is to consider surgical reversal. And if we go back 35 years, that was the only way available to really conceive after a tubal ligation. And the success rates of this were dependent on a couple of things. One, how much of the original tube was removed. If you had removed more than about 2 centimeters of tube, then there wouldn't be an adequate amount of tube left to allow adequate time for the sperm and egg to get together, begin to develop, and get to the uterus in a timely fashion. So you needed at least 5 centimeters of tube after you would go repair the tube. And we'll talk about repairing it in a second. The second concern is what part of the tube has been removed. If they remove the end of the tube where the little fingers are, the fimbriated end, then you can't fix the tube surgically. And if you have multiple burns in the tube or multiple cuts in the tube, then it's really not repairable. And if you have this E-Shore device that goes in the first portion of the tube that scars it in, that itself also is not reversible. So the only type of tubal ligation that's amenable to reversal is if there was a small insult given to usually the middle portion of the tube, so that from a surgical standpoint, you can go in, cut out the block segment, and put the two ends of the tube back together. The smaller the portion of the tube that was removed, the better the chance of a good outcome. The success rates following how you do tubal reversal surgery, you either do it with an incision, with microsurgery, or you do it with robotic or laparoscopic surgery, depending on the skill of the surgeon. Success rates, usually following a tubal reversal surgery, in at least 90% of cases, you would have at least one tube be remaining open following the surgery. Sometimes it would scar in, sometimes even though it would be open, the tube wouldn't work. But pregnancy rates would only be in women under age 40, where they have good sperm and they ovulate. Pregnancy rates would be about 60% over a period of 12 months. So the pregnancy rate per month would be about 5% per month in the first year following a tubal ligation reversal. And if it didn't happen within the first year, it usually was unlikely to happen spontaneously. So the type of ligation is important, how much tube is removed is important, whether there are other factors of sperm and ovulation is important, and most importantly, and more concerningly now compared to 35 years ago, the skill of the surgeon doing this procedure is very important. You got to do a lot of them to be good at them. And when I was a fellow and early in my practice, we used to do a lot of tubal reversal surgeries 30 years ago, because that was a way most patients wanted to be treated, and IVF success rates were not as good as they are now. The truth is most people prefer not to have surgery to reverse the tubes and then get pregnant that way, because once it's reversed, you're now fertile, and the whole point was to be non-fertile. Most patients who want their tubes reversed really only want one additional kid, so that doesn't make a whole lot of sense. The alternative to tubal reversal surgery is in vitro fertilization. And IVF is the ideal way to get pregnant. With IVF, the tubes stay blocked. So you have the advantage of built-in fertility prevention. Once you have your child, you haven't changed anything. The tubes are still blocked before and after. And what's done is you're put on fertility drugs to produce eggs. The eggs are removed by ultrasound guidance, fertilized in the dish, and the embryo is then transported back into the uterus. IVF was originally developed for patients with tubal disease. And so IVF is the ideal method to use to get pregnant when your tubes are blocked, but it's not the only method. If one is going to pursue a surgical approach, you need to have a surgeon that does a lot of these. And as I said, 25 years ago, I did a lot of these. Me personally, at this point, it's been at least 7 to 10 years since the last time we did a reversal. So if a patient is really adamant about wanting tubal surgery, I'll ask them to go find somebody who does a lot of these. And by a lot, I would think somebody should do 20 to 30 of these a year, 2 a month, to feel comfortable doing them. If you're not doing a minimal amount of these, you're not going to be real good at it. And the truth is, I don't even know of anybody in the South Florida area that does a lot of these. They may do 1 or 2 a year, and in all honesty, that's not the best surgeon to go to for this procedure. That aside, the reason not much is done is that IVF works so damn well. And with in vitro fertilization, in women that are under age 40, we're going to see really good success rates. And if you biopsy embryos, doesn't matter what your age is, if you put one normal embryo into a normal uterus, we should have close to a 50% pregnancy rate from that transfer of a genetically appropriate embryo into a normal uterus. And so the pregnancy rate is so much better, and that's with 1 month of treatment. It does not require surgery to go have this done. It does not require a long recovery period in any way, and it cuts to the chase. You don't have to have surgery. Now your tubes are open. Now you're waiting to see if it worked or not. And a year goes by, and then half the people still need to do IVF anyway, and they wasted all this time and money having surgery. So in my mind, IVF's the ideal preferred treatment. IVF success rates, as we've spoken before, are going to depend on having a normal uterus. Doesn't care about your tubes unless it's a dilated tube, and then that has to get dealt with. But most people who have tubal ligations don't have dilated tubes. It's going to depend on us having sperm, and and it's going to depend on the ovarian reserve. The quality of the ingredients matters. And even with tubal reversal surgery, if you don't have good sperm, why are you reversing the tube? It's not going to work. If you don't have good eggs or poor quality eggs, it's going to be harder to get pregnant, whether it's with IVF, natural conception, or following reversal of a sterilization. But at least with IVF and use of fertility drugs, we're getting more eggs available in a given cycle and a better chance of those eggs working. So that's it in a nutshell. In the options for women that have had a tubal ligation are either to consider tubal reversal surgery. If one is going to go down that route, you need to make sure that you're ovulating normally, you have a normal uterus, adequate sperm, and a surgeon who does a lot of these to give you a good chance of a good outcome. With IVF, it doesn't matter if the sperm is normal or not, doesn't matter if you ovulate or not. It does matter that you have a normal uterus, and the quality of the eggs is going to play a role in no matter what you do. So those are the two approaches. Either we reverse the sterilization or we do IVF. Most patients nowadays pursue the IVF route. It's quicker. The advantage of the tubes being ligated stay tied, so you don't have to worry about getting pregnant after you had the baby that you wanted. You don't need a surgery to put them back together, another surgery to tie them again afterwards, so to speak. And if you've cost-wise, you've got to balance all those things together. Obviously, there are advantages and disadvantages to both. So I hope that's helpful. Just a brief mention of sterilization on the male side, vasectomy reversal. Again, here we're dealing with an interruption in the tubular system that transports the sperm from the testicle to the outside world. And in men who've had sterilization procedures, you can reverse them. They're much more successful if they're done within the first 10 years, but again, it requires a microsurgical approach to reverse it. A lot of men who have a tubal reversal surgery, a vasectomy, will have anti-sperm antibodies present. So even though the sperm is now coming out, you've got antibodies that can attach to the sperm and make the sperm not function as well. And a tubal reversal surgery on a male should only be considered at all if we have normal anatomy, open tubes, and an ovulating female, so that you do the surgery and hopefully then you can have just sex the normal way and you get pregnant quickly. But again, if we compare what most people choose to do and the advantages of IVF, again, you have the advantage of the tubes, sterilization still being there after the fact and avoiding a major surgery and the potential of it not working and having to come back and do IVF anyway. So most of the time with tubal reversal, whether it's male or female, IVF becomes the major way to proceed. In the male who's had their tubes reversed, your question obviously is where does the sperm come from? And that comes from aspiration of sperm from the epididymis or the testicle directly, so we have sperm to fertilize the eggs even though nothing is coming out in the ejaculate. So have a good Monday. If we can be of help, let us know, and I hope this has been helpful and informative for everybody. Take care and have a good day.